He will be talking about ICD. The main focus of this talk will be ICD function, component, and indications. Inshallah, all of us will benefit from this lecture. Inshallah, we'll be able to incorporate and implement this in our day-to-day life, and eventually enable us to and help us to give the best treatment and therapy to our patients, inshallah. I would like to thank Dr. Baryun for his time and efforts to prepare for this presentation. And now I would like to briefly introduce our wonderful and honorable expert panel. Dr. Muhammad Abu Twirat from the UK, Dr. Esam Al-Halil from Libya, Dr. Yusuf Al-Darrat from the United States. Essentially, by the end of this lecture, inshallah, we'll give a chance to the expert panel to say a couple of words about the expert opinion about this presentation, and then we'll open it for discussion and to answer questions from the audience. Inshallah, we'll have a wonderful QA session after that. I would like to remind everybody that you can write questions on the chat box, and please mute yourselves and avoid interruption to the presenter, inshallah. And also, I'd like to remind you about the Libyan Cardiovascular Society conference, inshallah, in Libya in July. Please try to look at the invitation flyer, and please consider to attend that meeting, inshallah. From here, Esam, inshallah, I'm going to hand it over to you. You have the floor. You can share your slides. I think you're sharing them, and you can start recording from your end. You can start your presentation now. Thank you.
Thank you, Dr. Nawara, for your kind introduction. It's my pleasure to be here today to talk about ICDs. This is a very wide and broad subject.
Do you mind if you full screen of your slides? Full screen.
I have a full screen right now. Can you see it?
Yes, we can see it, yes.
You can see it now, yeah? Perfect.
Just speak a little bit louder.
Yeah, thank you very much for the introduction. Implantable ICDs apparently is a wide topic. We'll try our best to cover part of it today, and I'm sure there will be more talks about it later to complete the discussion. You know, the road to ICD started with an idea in the 1960s, and the first implanted ICD in an animal was 1975. The first in a human was 1980. At that time, it required thoracotomy, and the complication risk was high, about 5 to 9%, which made many physicians believe that it was probably not even ethical to do such high-risk procedures on old, sick patients. This is an example of one of the first ICDs implanted in the abdomen with thoracotomy required to get the ICD leads epicardial. And of course, this was non-programmable. So initially they were not calling them cardioverter defibrillators. They were just defibrillators because they could not be programmed to differentiate Vtac from VF. And the many patients who required these ICDs also needed a pacemaker, which would be a separate pacemaker for backup pacing if needed, which could lead to dangerous interactions. And of course, the life of the battery was only 1.5 years. In the 1990s, significant improvements occurred. Non-thoracotomy lead systems were similar to the subcutaneous ICD we have nowadays, where you implant the ICD generator on the side and you need a subcutaneous array in addition to a transvenous lead. In 1995, it got more simple, and the ICD was implanted in the deltoid groove in the chest with transvenous leads. This is an example of the more recent, less risk, fewer complications device. And of course, over the years, the number of ICDs implanted increased significantly. The better the ICDs got and the more evidence we had from different trials, as you can see, the number of implants skyrocketed. Now, sudden cardiac death management at that time started with antiarrhythmic therapy, apparently, and then ICDs were introduced. So many studies were conducted to test different antiarrhythmics to see if they really improve survival in these sick patients, from CAS to Camiod, Amyod, and so forth. The summary of all those studies is that antiarrhythmics may worsen the survival, and amiodarone may slightly improve the outcome. And of course, the medicines notorious for increasing death rates were the flecainide and anconide. After that, ICD trials started in the 1990s. Secondary prevention, CASH, AVID, and CIDS, and then primary prevention from MADED to MUST and MADED 2. So let's review shortly the different secondary prevention trials. Starting with AVID, patients were resuscitated. Patients who had a cardiac arrest and low EF, less than 40, were randomized between ICD and a class 3 medicine, amio versus sotalol. Of importance here, they did not compare the amio to sotalol, and they also did not make any comparison between different ICD models. The crossover was low, which is good, and the ICD proved to improve survival, especially in sicker patients. The controversy here is that people who had ICDs, of course, can tolerate beta blockers and also can tolerate higher doses of beta blockers because the ICDs are able to pace. Patients who did not get an ICD could not be on a beta blocker if they had sinus bradycardia, or cannot be on an adequate dose of beta blocker. So that was a significant difference where more beta blocker was given in the ICD group. In the CASH study, this was a long duration study, almost 10 years or more, but it was just a small study, only 192 patients. The reason is, when ICDs were first implanted at that time, they were requiring thoracotomy. So it wasn't easy to include patients in those studies. And the study compared drugs, which included propafenone, beta blocker, or amiodarone, to an ICD in patients who had cardiac arrest. Not surprisingly, propafenone arm was stopped very early, within a few years, because of the high mortality. Overall, survival was higher in the ICD arm. It was not significant, and that could have been related to the smaller size, only 192 patients. The Canadian Implantable Defibrillator study compared ICD to amiodarone. Included 659 patients, and it did show a reduction in mortality, but again, it was not statistically significant. And that could have been related to the early termination of the study after the AVID data were published. I like to compare studies in one slide so we can get a better idea. If you look here, you can see a significant difference in the number of patients. So 190 in CASH up to 1,000 in AVID. AVID was the only one that showed significant reduction in mortality. And I believe it is related to the fact that the patients included in AVID were the ones who had lower EF. In CIDS and CASH, low EF was not a reason to enroll. They enrolled everybody, even with EF of 45, 50. And because it's a larger study, so AVID had a significant decrease in mortality. Now, primary prevention trials are really the most important because the survival rate of cardiac arrest is really very low. So if 100 people have a cardiac arrest, you're only dealing with 8 of 100 out of 100 to give them an ICD for secondary prevention. So primary prevention, you will include a lot more people and save a lot more lives. And you can see that 80% of cardiac arrest have CAD, and 20% of patients with MI and heart failure will die within 5 years. So it's important, if we have very good primary prevention trials, we can save a significant number of patients who had an MI and have CHF. Primary prevention trials, I can divide it into the studies that looked at ischemic cardiomyopathy and the ones that included non-ischemic. These famous studies, MADIT, MUST, and MADIT-2, included only the ischemic cardiomyopathy patients. So the MADIT was one of the first ones, and of course, when the results came out of MADIT, they did not include the results in the guidelines because there was a lot of controversy about no registry of screened patients, and there was a high percentage of patients who stopped their amiodarone, and also there was a higher beta blocker percentage in the ICD group. But once the MUST trial results came out supporting what MADIT showed, then they included in the guidelines that ischemic cardiomyopathy with EF less than 35 qualifies for an ICD. So let's look at the MADIT trial. You had to have a history of MI, EF less than 35, documented non-sustained VT, and a positive EP study where you induce VT that's not suppressible even with procainamide. The New York Heart Association had to be class 1 to 3. And here they compared ICD group versus a class 3 antiarrhythmic. In the MUST study, the EF was less than 40 instead of 35. And you can see a discrepancy here between the three studies. In MADIT-2, less than 30. In MUST, it was less than 40. In MADIT, it was less than 35. Going forward in the future after these studies, they changed all the studies after that were using 35 as a cut line. And the reason is in the MADIT study, the highest benefit occurred in patients who had an EF of less than 26%. So comparing all three, we see here that the MUST study looked at an EF of less than 40 with non-ischemic cardiomyopathy, and they randomized them into EP study, directed therapy, or no antiarrhythmic therapy. And it's interesting in the MUST study that the way they did the EP study is they did 4 rounds. So they'll do an EP study on a patient. If they induce VT, they choose an antiarrhythmic. They bring them back for another EP study to see if they can induce Vtac in the patient with that certain antiarrhythmic. If it fails, they switch to another one. ICD was included in the MUST study only in patients who failed 2 rounds of antiarrhythmics. So ICD was included only in round 3 or 4. So the MUST study was not done to compare ICD to drugs. It was mainly to compare an EP study guided approach to no antiarrhythmic therapy. And interestingly, in the MUST, it showed that the ICD was the reason the EP study group had a less mortality. So what do we get out of the MUST study? EP studies were an accurate risk stratifier. If you have a positive EC study, you're at higher risk of sudden death. It also showed that the EP study is poor, has poor value to guide us on which antiarrhythmic therapy to use. So you will not use an EP study to tell you whether amiodarone or sotalol should be given, but you will use an EP study to tell you if the patient's at high risk or low risk of sudden cardiac death. MADIT-2, we just made it very simple. No need for EP study, because in MADIT and MUST both required an EP study. In MADIT-2, there's no need for EP study. Straightforward, lower the EF to 30 or less, and a history of MI, ICD proved to be better in reducing mortality 31%. So basically, ICD post-MI, without even doing an EP study, just having an EF of less than 30 was enough to deserve an ICD. Now, primary prevention for the non-ischemic cardiomyopathy. The only study that included only non-ischemic was the definite. The SCUD heft and companion included both ischemic and non-ischemic cardiomyopathy. Here's another comparison. So the time that these studies were done were late 1990s to early 2000. And you can see there's a significant difference if you compare the previous. When you look at the beta blocker used was only 18% and made it, 40% and must, and 70% and made it too. Now, if you go down here, you look at the beta blocker used at the end of the 1990s, it became more popular to use beta blocker for CHF compared to the 1980s. Now, definite ICD with standard medical therapy versus standard medical therapy alone. So in the definite, we're not comparing ICD to another antiarrhythmic. We're comparing standard medical therapy for CHF and coronary artery disease with and without an ICD. In the SCUD-HF, the comparison was an arm for ICD, an arm for amiodarone, and another arm placebo, comparing nothing to amiodarone to ICD. And the companion study, it was optical medical therapy for CHF compared to CRTP compared to CRTD, in addition to optical medical therapy. The patients included, again, the EF was the same for all three. It was 35 or less. New York Heart Association enrollment differed a little bit, where the definite included anything from 1 to 3, but the CRT study included only 3 and 4 heart failure classification, and the SCUD-HF included 2 and 3. Overall, there was a significant reduction in death in the definite group, and there was so significant reduction in death from arrhythmia, but not overall mortality in the definite group. And the reduced mortality was 35% with adjustment of the p-value to 0.08. So there was no significant reduction in mortality in definite. There was a reduced mortality in the SCUD-HF, where ICD was definitely better than amio. And in the CRT companion study, the CRTP alone reduced hospitalizations and improved quality of life, but the CRTD is what decreased mortality. And the only problem with the companion is that there was a high number of patients who withdrew from the medical therapy towards the CRT, which supports the fact that the CRT was pretty effective. So in general, if we're going to summarize primary prevention indications for ICD, to make it simple, if the EF is less than 30, then it doesn't matter if you have heart failure symptoms or not. It doesn't matter if you're ischemic or non-ischemic. If your EF is 30 to 35, there's not a class 1 indication to put an ICD unless you have CHF symptoms. Whether you're ischemic or non-ischemic doesn't matter. If you have an EF of 30 to 35 with CHF symptoms, you qualify for an ICD. If you don't have CHF symptoms, then you're not a class 1. It's going to be a class 2B, which means you're going to be a less risk patient. EF of 35 to 40. EF 35 to 40. To qualify for an ICD, you have to have non-sustained Vtac documented, history of MI, and then a positive EP study that induces VF or VT. Unstable VT, of course. So ICD should be avoided in the first 40 days post-MI, within 3 months post-revascularization, and in New York Heart Association class 4, unless they need a CRT, or in non-ischemic cardiomyopathy, EF 35 to 40. So an EF of 35 to 40, non-ischemic, there's no indication for ICD for primary prevention. If that patient passes out and the syncope is unclear etiology, that qualifies him for an ICD as a class 2A for secondary prevention, not primary. But for primary prevention, EF 35 to 40, if you're non-ischemic, you don't get an ICD. If you're ischemic, you can't get an ICD if you have non-sustained Vtac on a monitor with history of MI, if the EP study is positive. This is just a simple diagram showing where it's indicated or may be indicated. So there's a weak recommendation when the EF is 31 to 35. Really, indication is not as strong. You really need CHF symptoms to support that. Secondary prevention indications, probably a little bit easier. If you have a cardiac arrest, and they're making it clear that it's not just a VF, if it's a Vtac, it has to be sustained and it has to be unstable. If your Vtac is sustained but stable, then it's not a class 1 indication unless you have structural heart disease. If your Vtac is sustained and stable with a preserved EF, it's not a class 1 indication to implant an ICD. And this is important to recognize because the studies that were done to prove ICD improved survival did not include patients with stable, sustained Vtac. They only included patients with Vtac that led to syncope, Vtac that led to severe hypotension, or a cardiac arrest. So a patient walks into the ER with a Vtac 160 beats a minute, with a blood pressure of 100/50, that patient is not does not qualify as a class 1 indication for ICD. Now, syncope could be a little bit tricky because if the patient passes out and you don't know why, there's no reason, the glucose was normal, blood pressure fine, no bradycardia, that could have been a cardiac arrest. So a syncope of unclear etiology in these sick patients is usually considered as a cardiac arrest until proven otherwise. And if you have syncope and you have a positive EP study, then that is a class 1 indication for an ICD. You could get an ICD as a class 2A if you have moderate to severe cardiomyopathy with syncope, but it's still not a class 1 indication. And again, if the prognosis is less than a year, like patients with cancer who have poor prognosis, then it's better not to implant because the risk of dying from an ICD implant is present. So you have to have the risk-benefit ratio has to favor an ICD. You have to have a prognosis of more than a year. And this is just to remind ourselves that the ST elevation MI guidelines support the fact in secondary prevention, you qualify for ICD if you have a cardiac arrest more than 48 hours after the ST elevation MI, provided that there's no reversible cause. This slide, I want just to show two things. Number one, the ischemic versus non-ischemic cardiomyopathy, class 1A versus B. So you can see ischemic cardiomyopathy is always higher risk than non-ischemic cardiomyopathy. And then in the down part of the slide, you can see that even for CRT, how wide the QRS will explain you have a stronger reason to implant a CRT if the QRS is wider. When should we not implant an ICD? We talked about the survival. That's one thing. If the cause of cardiac arrest is reversible. Now, there are times it's reversible, but you still get an ICD because you know it's going to happen again. You know, patients who have certain kidney disease where they lose magnesium and lose potassium, and they're always at risk of recurrent hypokalemia and hypomagnesemia. If the nephrologist thinks he cannot control that and the patient is at risk, then you could probably implant an ICD. But in general, reversible cause, no ICD. Low survival, no ICD. Significant psychiatric illnesses is a big one also. You know, this may include people who are demented and don't understand what it means to get shocked. And the last point is patients who have VT amenable to surgical or catheter ablation. You know, ventricular arrhythmias caused by WPW, outflow tract Vtac, bundle branch reentry. These are treatable, and there may not be a reason to put an ICD. Another reason I can add is patients who have a scar, a small scar, let's say a small inferior scar caused by an MI in a young patient who has stable VT, and you prove it's from that small scar. If you feel comfortable ablating that scar or modifying it, with a high success rate, then you can consider not implanting an ICD. And I remember doing that 10 years ago in a 38-year-old patient who had an MI scar and was having a stable VT from that small scar. He got ablated and never needed an ICD. You can always put a live vest for a few months just to be on the safe side. Now, some patients were not included in the studies that we just reviewed. And that's why there was a statement in May 2014 where they looked at ICD therapy in patients who were not included. Example for those, people with positive troponin but not considered to be an acute MI, ICD could be implanted in those patients. You don't have to wait. Or patients in 40 days of an MI, we'll talk about that in more detail, but it's not recommended to implant an ICD for primary prevention in the first 40 days of an MI, unless you need to pace the patient. If the patient really needs an urgent need for pacing, then an ICD could be implanted. ICD within 90 days of revascularization, I have a slide on that, and then ICD in the first 9 months after diagnosis of ischemic cardiomyopathy. Now, non-ischemic cardiomyopathy, I'll tell you, if the patient feels better after 3 months of CHF therapy and the EF does not improve, I still wait another 3 months. And I've seen many times it may take non-ischemic cardiomyopathy 6 months to improve their EF. So I look at it clinically. If there's a significant improvement in symptoms with CHF therapy and the EF is still in less than 35, I will give them another 3 months or another 2 months. And many times I've seen the EF increase in an impressive way. So the studies that looked at ICD early after an MI, Dynamit and IRIS. Dynamit, patients with recent MI within 40 days, EF less than 35, and a depressed heart rate and variability. The ICD did not reduce mortality. Now, it reduced arrhythmia death, but that was offset by an increase in death caused by recurrent MI, caused by wall rupture, papillary muscle rupture, and so forth. Interestingly, in the Made It 2 sub-study, the maximum benefit of ICD was after 18 months post-MI. And based on that, ICD is not indicated early post-MI, even if the EF is low. So early post-MI, 6-month period immediately following MI, there's a high risk of sudden death, but the arrhythmia death is not more common than the non-arrhythmia death. So non-arrhythmia death up to 80% in the first month. By 1 year, the arrhythmia death will equal the non-arrhythmia death. So at 30 months post-MI, 60% of death is related to arrhythmia. So you can see very clearly that early MI, there's going to be causes of death, that the ICD will be a waste of time and money in those patients. Now, ICD may even harm patients in early MI because the shock can result in myocardial injury. And also pacing can worsen the EF. So to summarize, ICD within 40 days after an MI, when do I do an ICD early? Number one, if the patient needs to be paced, and we talked about that. Number two, if it becomes a secondary prevention, not a primary prevention. So primary prevention, you're always going to wait unless the patient needs to be paced. But if the patient passes out, syncope, or if the patient has a cardiac arrest within that 40 days, let's say he goes home after an acute MI, comes back in 2 weeks with a cardiac arrest, that patient needs an ICD, unless you can prove that that cardiac arrest was secondary to ischemia or secondary to a recurrent MI, or is something that is reversible that could be fixed, like a bundle branch reentry VT or an outflow tract VT. And they make it clear at the end it's a clinical decision. You can decide as a cardiologist whether you think this is, so it has to be unstable, has to be sustained, and has to be non-reversible. If the patient has syncope and you don't even know you're not 100% sure that it's a Vtac, then based on the clinical history or even an EP study, you can decide to implant an ICD. So what about ICD within 90 days of revascularization? ICDs within 90 days, a lot of things to put in mind. The reason we wait after revascularization, we hope that ejection fraction is going to improve. The sub-study showed that there's an increased survival benefit as time moves. And live vest nowadays is a good way to do it. You can wait and just give the patient a live vest if you think that there's risk. So in general, cardiac MRI showing scars could help you predict if the EF is going to improve or not. If the patient has scar all over and you're not expecting the EF to improve, it really doesn't make sense to wait 3 months because a cardiologist stented the OM. So in general, that's very important to look at also. So to summarize, within 90 days, if it's primary prevention and you don't expect the EF to improve, like the example I just gave, or if there's secondary prevention and the cardiac arrest is not reversible, not secondary to an MI. If syncope is likely secondary to Vtac, then there's no need to wait 90 days. Or if there's pacemaker indicated, there's no need to wait. So in general, ICD is not indicated if the EF is normal and the Vtac that occurs within 3 months post-revascularization is considered to be reversible or secondary to an acute MI that underwent complete revascularization. Now, MI without revascularization is a different story. Then you have to implant the ICD because you're not expecting the patient to improve. And of course, Vtac in the setting of scar, that substrate's always going to be there. So it doesn't matter if someone revascularized an LAD and the patient has a Vtac from an inferior scar, logically, the patient is going to require an ICD because the scar's still there and it's going to cause Vtac again. This is an important topic here. It's not common, but there are disease entities that are not common, but they cause progressive AV block. And I'm going to give 2 scenarios here. A patient presents with AV block, his EF is 45%. Now, logically, you're going to give a pacemaker because he does not qualify for ICD. But it's important to always remember we need to rule out these rare disease entities from muscular dystrophy to LMNA gene mutation to cardiac sarcoidosis to giant cell myocarditis that are known to cause both AV block and cardiomyopathy. Some patients present with cardiomyopathy first and develop AV block later. Some patients will have AV block first and then develop cardiomyopathy later. And the important thing here is if you identify these disease entities, if you decide you're going to put an ICD because the EF is low, you're going to do a dual chamber ICD because they're going to have an AV block in the future rather than a single, and then you need to upgrade. And if the patient comes first with an AV block, you're not going to put a pacemaker, you're going to put an ICD because you know the patient's going to have. And you can see here in these disease entities that there was a significant people who died who had pacemakers. You can see here down in giant cell myocarditis, there was 4 patients died. And here in the other study, they had 9 patients died. So in general, remember patients who have sarcoid in the lung and now they have an EF of 40 and they develop an AV block, rule out cardiac sarcoidosis. If the patient has a significant increase in cardiac markers, think about giant cell myocarditis. And then the muscle dystrophies are, I believe, the easiest to diagnose. The LMNA gene mutation is rare, but you can really identify it usually from family history. And usually the story is a young man, his brother died, and he was tested and found to have LMNA, and now he needs an ICD. His PR is 200, so you'll implant a dual chamber rather than a single chamber ICD because you're expecting AV block. This summarizes everything for people who want to look at it later. Okay, so ICD hardware, we have the battery of the ICD is different from the pacemaker. Pacemakers are lithium iodine, but the battery of the ICD is a lithium SVO, which is a silver vanadium oxide. You can't shock with just a low voltage battery, and that's why ICDs require capacitors. It's like a reservoir. It stores electrical charge over time, and then it produces it at once. Of course, the bigger the ICD, the shorter the charge time. You reduce the size of the capacitor in the battery, the charge time will increase. If you have increase in resistance, especially shock resistance, that's going to significantly increase your charge time too. And near RI, the charge time also will increase. The capacitor is really composed of two surfaces and separated by an insulating material, usually plastic or dry air. And then you have the leads and electrodes, and then a microprocessor with integrated circuits. With ICDs, we have two types of leads. You can have a single coil or a dual coil. For people who do extraction, they don't like the dual coil because it adheres more to the SVC. Then you got true bipolar versus integrated bipolar. In integrated bipolar, it's a way where companies try to make the synthesis of the lead more simple, where there's no ring, but they use the distal coil as a ring. I mean, that could have a benefit, but it also has some downfalls, like as we will see on the next slide. And then we have ancillary defibrillation of electrodes if needed, like a subcutaneous array, a subcutaneous patch. The lead construction, it could be coaxial versus multilumen. Multilumen, we see it more in a dual coil system. This is a very quick schematic diagram of integrated bipolar, where you have more oversensing and also more undersensing. It may make the structure of the lead more simple, but then it could get us in trouble. And this is an example where diaphragm myopotential was sensed and led to no pacing. So discriminators between single and dual chamber, if you have only one lead, the only way to differentiate between SVT and VT is using stability, sudden onset, and morphology. And we'll look at that in the next slide. And then if you have two leads, you can count the A and the V. You can notice which one starts first, the pattern of P and R, and then you can look also at is it caused by premature stimulation versus a sensed event. Ventricular stability, as we can see here, will help discriminate VT from AFib. And the sudden onset will help rule out the sinus tachycardia, as we expect it to be more gradual onset. In single chamber discriminators, morphology is very helpful, but sometimes if you give antiarrhythmic drugs, that can change the QRS, or if patient develops aberrancy. This is the dual chamber discriminators. Of course, the challenge is also always is the undersensing of the AFib. So you can diagnose AFib with RVR as Vtac if the atrial lead did not sense the AFib. And you can also have an issue with oversensing for a field where you can diagnose Vtac as SVT. ICD therapy in general, the painless therapy and the painful therapy, the ICD shock will drain the battery, so it doesn't just hurt the patient, but also reduces the longevity of the device. With ATB, it can be burst or ramp. Burst is very fast. If it's very fast and very long, it can cause VT to generate into VF, so we try to make the burst shorter. In slow VTs, I've seen even 3 to 4 beats enough to terminate. Of course, you have to be more aggressive. It has to be 60% of the VT cycle length. The faster the VT, then you can go closer to 88%. Ramp, pacing rate accelerates in ramp. That's different from the burst. The burst will be more stable. RAM pacing more likely will accelerate a fast VT. So in fast VTs, I prefer bursts. In slow VTs, the effects are the same. ATP can terminate VT in 80% of patients, and that's a pretty good thing. It improves quality of life, and it also extends the battery life. Both shocks and ATP can be proarrhythmic. ATP has more success with slower VTs. ATP can also delay conversion to normal. So if the Vtac was going to terminate and you pace it, you can keep it going. They have the same risk of sudden cardiac death. Important to remember that ATP success is more in people who have better EFs. So people who have an ejection fraction of 15%, you don't want to do a lot of ATPs on that patient. So lower EF, less ATP. There's no difference in success between ischemic and non-ischemic when it comes to ATP therapy. Studies looked at quality of life, pain-free treatment too. ATP is effective for fast VT. At some point in time, we were avoiding ATP in fast VT, thinking we can degenerate it into VF, but this study showed that you still have a good chance of even terminating fast VTs with ATP. And they showed that they can terminate up to Vtacs that were 250 beats a minute without need for painful shock. So in general, to reduce shocks, patient selection, of course, is one. Electrolytes, ischemia and CHF management, always optimizing medical therapy. Antiarrhythmic agents could help slow down Vtac and make ATP more successful. Ablation is a big one, not just ablation of Vtac, but also patients who have CHF and AFib. Ablating the AFib reduces the Vtac recurrence. It improves the hemodynamics of the heart. And then CRT, adding an LV lead is not a bad idea in some patients. Another way to reduce shocks is also to delay the therapy. 30/40 VF NID is recommended now. We avoid shocking quickly, especially if the patient has Vtac and tolerates it well. There's no need to shock quickly. Increasing the duration to detection is very helpful. So programming number of intervals changed over the years. It was 18 to 24 for the VF, and now it's up to 30 to 40. And we've seen the same thing with Vtac. We increase it now up to 32. Now, the shocks that are weak, if you try to save battery by reducing the shock, you may harm the patient by accelerating the Vtac to VF. There's not significant difference in shock pain based on the strength. And then remember, unnecessary effects of excessive shock include the rapid battery depletion, and then the depressed contractility. Shocking too much can lead to electromechanical dissociation. And of course, remember, the higher that you shock, the more excessive, when you have excessive shocks or successive shocks, the charge time will increase also. Pacing threshold increases post high voltage shock. And we see this also in AFib. When you cardiovert a patient who has a single or a pacemaker, a lot of times within the first few seconds after the shock, the pacemaker will not capture. I don't know if someone else noticed that or not, but that does happen. Post-shock bradycardia pacing is programmed at high output because of this phenomena. And again, the post-shock bradycardia can be proarrhythmic in itself, and that's one of the reasons nowadays even the subcutaneous ICD paces for the first few seconds after the shock. In general, we always want to minimize RV pacing. Now, antiarrhythmic medications in patients with ICD, we have to be careful because if you slow down the VT, then the cutoff rate, the patient will not get therapy. You will allow more successful ATP. And of course, some medicines can widen the QRS and change the morphology criteria. Pacing patients will get more paced when they develop AV blocks secondary to antiarrhythmics. And then, of course, the defibrillation threshold, as I will show in the next few slides. So sodium channel blockers in general increase DFT, potassium channel blockers decrease DFT. Antiarrhythmic drugs could affect the pacing and the QRS morphology. And here it shows that the DFT, the only two that we know clearly decreases DFT is sotalol and dofetilide. So rarely we may change amio to sotalol if we have a high DFT patient. Of course, sotalol you can't give with EF less than 40, so it's always a challenge. Here's another example how antiarrhythmics can affect. It's the conversion of AFib to flutter 1-to-1. So if that patients can, with ICDs, you're treating them with antiarrhythmics for the AFib, you can put them in flutter 1-to-1 and cause an inappropriate shock. Another table that kind of repeats what we just talked about. So undersensing could happen from 1A and 1C group, failure to capture 1C and amiodarone, failure to detect all of the above. Don't forget the acute hyperkalemia and its causes. Not just it can cause Vtac, it can widen the QRS, it can cause T-wave oversensing, and this is important in ICD patients with renal failure. So patients in VF and no therapy occurs. What are the causes? Well, part of it's programming. If we inactivate the ICD, if the Vtac is slower than detection, if we have issues with discriminators, and if there is intra-device software interactions. Undersensing is a big problem, especially when the R wave, that's why we want the R wave sensing to be above 5. Pulse generator lead failure, and then device interacting with another type of stimulator. Magnet application on pacemakers will force it DOO or VOO, making the sensing circuit inactive, but in ICDs it's a little bit different. It disables the tachycardia function. So it does not influence bradycardia function in ICDs. The sensing circuit remains active. This is helpful in multiple inappropriate shocks or if the patient's in the OR. For primary prevention, it's okay to drive a non-commercial private car, but for secondary prevention, no commercial driving at all forever, but 6 months for non-commercial driving. Subcutaneous ICD, the question is pros and cons, where the device is implanted on the side and the ICD lead is tunneled, so there's no transvenous lead. The pros of subcutaneous ICD. Of course, when you have a lead inside the heart, it's going to be moving continuously. That increases the risk of mechanical stress. So there's no mechanical stress on a subcutaneous ICD lead. And the less risk of clavicular crush, especially in young people who swim and are very active. It's good for patients who are at risk of lead infection, like dialysis patients. And of course, no radiation to me as an operator is a big one too. Now, what are the cons? Higher DFT, and it cannot pace. The only time it paces is the first few seconds after a shock. And then no CRT. So if a patient needs a CRT or needs ATP therapy, you cannot implant a subcutaneous ICD. And that concludes the presentation, and I welcome any questions.
Thank you, Esam. Fantastic talk. I really appreciate the time you took to present this fantastic presentation. I'm well aware of the time, so I'll just say a couple of comments, and then we'll give a chance to the expert panel to say a few comments as well. Do you hear me okay, Esam?
Yes, I do.
Perfect. So just to remind everybody, especially juniors, about the ICD, I always say ICD, what ICD stands for, as clearly mentioned in the title of this presentation. It's Implantable Cardioverter Defibrillator. It's not like internal cardiac defibrillator, or certain people think it's not to be clearly known. The name itself speaks for itself. So implantable, that means implanted, cardioverter, cardioverts, and defibrillator, that means defibrillates. So treats VT and VFib and cardioverts any arrhythmia. ICD is for secondary and primary prevention. So it prevents sudden death. So remember, we don't use those devices to treat the underlying cause. For example, if you have ischemia or cardiomyopathy, so we have to really implement the guidelines, directed medical therapy. On the top of that, we can add ICD when it's indicated. And mainly ICD is to prevent sudden death, which means VFib or pulseless VT, as Dr. Baryun mentioned, and from primary and secondary preventions as clearly were written by the guidelines. So now we'll open for the expert panel. I will give a chance to everyone. I will start with Dr. Mohammed Twarat, then Dr. Sam Halil, then Dr. Yusuf Darrat. So Dr. Mohammed Twarat, are you able, or if you can hear me, if you can give us a couple of wisdom comments about this presentation?
Thank you very much, Dr. Esam. Baryun very well presented talk, and very well summarized as well. Started with the history and ICD indications, and also regarding the studies and the comparison between majority of the studies. One of the questions, I mean, I think already raised by one of the doctors in the chat comments regarding when to probably think about stopping antiarrhythmic medication when implanting ICD, which may probably Dr. Esam may give us a little bit of information about this. I mean, as you know, majority of patients started with arrhythmia, treated initially with amiodarone, and then what's the evidence of leaving them on amiodarone in presence of the ICD?
Okay, yeah, thanks, Dr. Mohammed, for excellent comment. I will move to Dr. Sam Halil to say his comments, then we'll open it for more questions. And we'll definitely comment on this very question of yours, Dr. Mohammed. Do you hear me okay, Usama?
نعم دكتور عبد الغني. اولا شكرا دكتور عصام على النايس برزنتيشن. الحقيقه اعطيت سمري كويس للاي سي دي، بديت من الهيستوري للانديكيشن للفاريوس بوينتس. الصراحه الحقيقه I was fascinated من زمان بالاي سي دي. طبعا احنا عندنا ككارديولوجي او كدكتورز نشتغلوا في الفيلد اوف كارديولوجي، عندنا حاجتين to save the life of patients. عندنا البرايمري بي سي اي وعندنا الاي سي دي. هذوما they save lives actually. فالحقيقه الانديكيشن اوف اي سي دي implantation is very crucial. ليش؟ وهذه ممكن we are facing a lot of problems. ان many patients after ICD implantation they will suffer من الشوكس، وكانت inappropriate shocks. It's الحقيقه very painful experience سواء كانت inappropriate ولا appropriate shock. many patients they come back to you, doctor please take out this device from me. فهذا علاش بارك الله فيك دكتور عصام انت غطيت الانديكيشن للاي سي دي امبلانتيشن in a very detailed way. وزي ما قلت لكم الحقيقه الانديكيشن should be always revised، لان ما هيش حاجه سهله ان patient experiencing الشوك which is very painful. الحقيقه ممكن حاجيك بعدها واحنا الحقيقه في بلادنا اتليست مانيش عارف السايكولوجيكال سبورت ولا السايكولوجيكال سبورت البيشنت بتاع الاي سي دي امبلانتيشن ما عندناش. فهذه واحده من البوينتس اللي وي هاف تو فوكس على الفيوتشر على الاقل في الكارير تاعنا. النقطة الثانية اللي هي ممكن بعدين طرحوا لها الزملاء اللي هي storms. How to manage storms, especially the young doctors اللي يشتغلوا في الاي سي يو ولا في الاسعاف. I would like to thank again my colleague Dr. عصام. It was very nice lecture حقيقة. شكرا عبد الغني.
شكرا دكتور أسامة. الله يبارك فيك. Excellent comments. I would definitely add to what you insisted to say. Is the indication is very important, and to revise, especially the ejection fraction. You'll be surprised to see ejection fraction of 20% now, and by just giving them their optimal medical therapy and review and repeat the echo in like a couple of months, you'll see ejection fraction went up to 50 or 60%, and you save the patient from going to an ICD. So an ICD indication is there, but it has to be clearly based on the guidelines, especially timing of the ICD implantation. Okay, so Dr. Yusuf Al-Darrat, if you want to add a couple of comments for the presentation.
السلام عليكم.
ورحمة الله.
عصام بارك الله فيك على البرزنتيشن. يعني هل بحاجات تكلمت عليها في وقت قصير، لكن كانت برزنتيشن ممتازة. النقاط الاي سي دي طبعا البرايمري بريفنشن فيرسس السكندري بريفنشن مهم ان الواحد يعرف الانديكيشنز. I agree with أسامة بليل ان two things to save lives في الكارديولوجي البي سي اي والاي سي ديز. فدفني الاي سي ديز هذه حاجة مهمة، لازم نعرف الانديكيشنز لها و how to manage اي سي ديز. أنا عندي في أسئلة هي انطرحت في الشات بوكس، فlet's address those questions. أنا مهم جدا إن we address the questions to our junior colleagues. مش عارف إذا شفت الأسئلة هذه.
I saw them, Yusuf. I saw them. Just to have a quick question, Esam, before that. Allah يبارك فيك, Yusuf. Excellent comments, and I will start with the questions now. Esam, if you can comment on the Danish trial. Danish trial came out a couple of years ago, and it was negative for secondary prevention for non-ischemic cardiomyopathy. Non-ischemic cardiomyopathy do not benefit, or patients who have non-ischemic cardiomyopathy won't benefit from ICD implantation. If you can comment on how can you incorporate this in the guidelines?
Yeah, thank you for asking that question. I mean, like I showed in many slides, there was a slide mentioning that 80% of sudden cardiac death are CAD patients, coronary artery disease patients. So, and also the study showing that usually when the EF is less than 35, it's a stronger indication and usually class 1 for ischemic versus non-ischemic. So from the get-go, from the 1990s, it was clear that ischemic cardiomyopathy is a higher cause of death than non-ischemic. And also with non-ischemic, I see more likely for the EF to improve with medical therapy compared to the ischemic who already have scars. So that's one of the reasons we had to wait up to 9 months before versus, just 3. When I have an ischemic cardiomyopathy, I usually don't wait more than 3 months. With non-ischemic, I have no problem waiting 9 months because the risk of death we know is less than ischemic.
Thank you, Esam. Excellent. Thank you. I will ask Dr. Abu Tuwairat if you can answer the first question about are any sustained VT. Anybody is every patient with sustained VT requires coronary angiography to exclude ischemia, especially if the patient is young?
Answer, of course, depends on the history and I mean, nowadays, young, whether they are smokers or not, depending on the history of, if there is any suspected coronary artery disease or not. There is how young is the patient? I mean, if someone probably child, definitely not. But I mean, the echocardiogram will probably show. The most important thing is the cardiac MRI scan to see if there is any scar or any cardiomyopathy evidence, and then you decide according to everything. You incorporate genetic tests and things like this to decide, and the ECG, of course, if there is indication for an ICD. I think the question very likely is for someone in the adult age, 20s or something, male, and presented maybe with a sudden loss of conscious. If there is no clear indication from the history or from the ECG, I don't think an angiogram will be. I mean, if someone recovered completely, I think the angiogram is not going to add too much risk to do it if there is a need for it, really, because there is other reasons other than rupture of blood, maybe dissection or something like this. You have to exclude that. There is a lot of other investigations just to look for systemic disease, vasculitis, things like this, which may also present. So an angiogram within the first day or so is still indicated if you're thinking about unknown cause for cardiac arrest. I don't know what to think, other colleagues.
Sure, thank you so much. Yeah, excellent, excellent. Just I might add that the clinical scenario is very important. The patient comes with ischemic symptoms. Polymorphic VT, usually it's ischemia driven, whereas monomorphic VT is usually scar related or something else, less likely to be ischemia. VFib is obviously has to be dealt differently with. I see Dr. Abdul Kafi Tashani here. I'm really pleased to see him here today with us, my friend Abdul Kafi. Do you hear me, Abdul Kafi? I would like really to hear from you and your input about this presentation, if you can. Abdul Kafi? Unmute yourself, Abdul Kafi, if you can. Okay, once we hear from Abdul Kafi, inshallah, we'll come back. If any comments about this first question from the other colleagues, anybody want to add, Usama or Yusuf?
والحقيقة دكتور محمد غطى الموضوع. هو ديما الكلينيكال سيناريو هو اللي ليه التوب برايورتي في الجادجمنت، هل البيشنت يستحق لي انجيو ولا لا. بس حاليا في الايرا نتاع الكارديك MRI والحمد لله تو متوفر في ليبيا، يعني ميني بروبلم سولفد. يعني تقدر تشوف اذا كان البيشنت عنده سكار هل يستحق لي انجيو ما يستحقش لي انجيو، هل هي كارديوميوباثي ولا اديوباثيك بي تي. فاعتقد ان هذه clinical scenario oriented، يعني how the patient presented, the risk factor, الاي سي جي اذا كان في any changes. وزي ما قلت الكارديك MRI now it's available, so many problems ولا many questions answered without rushing the patient.
Excellent. Okay.
يعني بس الكومنت هو نفس الكومنت. البيشنت لو ما عندهاش انجلا تشست بين ما فيش داعي. يعني لو زي ما قلت كان مونومورفيك VT هذه سكار ميديتد، هذه نوت اسكيميا دريفن. الا لو البيشنت عنده انجلا عنده تشست بين you're going to do a hard cath for that. لو polymorphic VT I strongly recommend ischemic workup.
Totally agree with you, Yusuf. Okay, so Usama, if you can answer this question about when you consider single chamber ICD, just briefly. I think Esam covered it very well, but this is a question risen here.
Single chamber ولا subcutaneous ICD؟ تأكد من السؤال.
Whatever you can, just let us single chamber ICD, then we'll move. There are two questions. First one is single chamber, then the second one is subcutaneous.
I see, sorry.
Yeah, it's okay.
مش عارف my comment about that in a single chamber ICD most of the time it works unless ان عندك risk of SVT you need more discriminations, then the atrial lead will add to your ICD discrimination modality. لكن ال single chamber ICD most of the time works unless ان زي ما قلنا البيشنت عنده supraventricular arrhythmias, then the atrial lead will add a value to your discrimination detection and discrimination of the
Definitely,
Yes,
I agree with you. I also I might add is the chronic AFib. That's only exclusion I would use to avoid single lead. If you have chronic AFib, then atrial lead will be useless.
Yes, in chronic AFib, yes, you forget the atrial lead. Yes.
Perfect.
Yeah, and there's also a company that makes an ICD lead that can sense the atrium. So you have a single chamber ICD with the ability to sense the atrium to DX and Biotronic.
Definitely, yeah. Yeah,
In
the
primary-
sensitivity is a bit low, but definitely it's available.
In primary prevention, we use single chamber ICD because unless there is indication for pacing, otherwise, if it is just primary prevention and there's no plan for pacing for the future, we use a single chamber, especially it depends on the age of the patient as well, just to avoid too many leads early in life. So it may probably be more than enough to cover primary prevention. I don't know what the practice in the UK or in Canada.
Yeah, in
For
general,
primary prevention.
the rule is to minimize hardware in the patient's body. So, for example, a low EF patient, like you mentioned, with primary prevention, especially in young patients, I would go more with single, but the older patients, especially if they have AFib and you're expecting they're going to need a lot of beta blocker, or someone may start amiodarone, it's going to be sad to give an ICD and then you see him a year later and he's sinus bradycardia. So I like to do single leads. I mean, even my pacemakers, most of them are single A. I don't even do the V lead unless I really have to. Going back to the question of the Vtac store, I mean, that needs, I think, a lecture in itself. But just to summarize, I think it's with Vtac Storm, it's like it's not really an EP specialty management. It needs a multidisciplinary approach where you need an intensive care person, you need general cardiology to optimize CHF. You need a lot of different specialists, because in addition to beta blocker and antiarrhythmics, then you end up doing intubation and sedation. And then after intubation and sedation, ablation could be an option. And we see patients that do very well with neuroaxial modulation, which is the sympathetic denervation. So in general, it's really it's a long topic to discuss, but that's just in general, maximize beta blocker, antiarrhythmic therapy, intubation, sedation, and then some patients will just have to need sympathetic denervation, which is not common but could be used.
Perfect. Yeah, thanks, Esam. That's a question I was planning to answer.
بس I'm going to add something بالنسبة للسنجل chamber versus dual chamber, something else to add. يعني لأن كانوا مدارين study David trial، لو تسمع بها David trial, they implanted dual chamber versus single chamber ICDs. So they showed that with more pacing, there's more adverse outcomes. فلو patient doesn't have a pacing indication, single chamber, I agree with everyone. لكن نبي بس نفكر بالستاديز اللي اندارت اللي showed that that's why we do VVI 40 based on that one of the studies اللي هي David trial.
Now, yeah, that's a pacemaker trial, and I totally agree. That's why here
It's
in Canada,
it's an ICD trial. It's an ICD dual chamber and VVI implantable defibrillator David trial.
Yeah, also there are, I think it's both ICD and mostly pacemakers, but definitely the focus was the single versus dual.
The single versus dual. والسنجل يعني المور هذه الترايل اللي بينت ان more pacing worse outcomes. 40% pacing or more is worse outcome. فبلاش don't put a dual chamber unless the patient really needs pacing يعني. If the F is low, you need a BiV. هذا اللي دوي عليه عصام يعني.
Yeah, totally agree. The main thing is single lead pacemaker when have the chronic AFib. Otherwise, it's definitely a personal choice. In our center, we do all dual chambers except when have chronic AFib or young patients who there is no need for dual. That the main reason is to prevent right-sided pacing which can cause heart failure, and also there's evidence that can affect the atrial fibrillation therapy and probably increase mortality if it's a young patient with a single lead.
Yeah, and if the patient needs a single chamber ICD, the question is always going to be, should I do subcutaneous ICD versus transvenous? And another reason to go towards a transvenous is if the patient is very obese or very big, the chances of not, defibrillating with a transcutaneous is probably higher because we have less experience with it.
I agree. Perfect. I think somebody has his hand. So Dr. Oakley, أو رضا يومك طيب دكتور رضا العوقلي تسمع فيها. Unmute yourself if you can, and you can put your camera on. You have the floor. Dr. Rida Al-Awkli, if you can unmute yourself. Dr. Tashani, Abdelkafi Tashani موجود. If you can unmute yourself, you can say a couple of words. Okay, Esam, سؤال from the audience على frequent ICD shocks. What considerations should be taken in patients with frequent ICD shocks? You answered that very nicely in the presentation. Just if you can summarize it, a couple of words.
The question is how to reduce?
Yeah, consideration. How to, consideration to take. And that means how to reduce or avoid it.
One way to reduce the shock, interesting, is that you control the Vtac before you put the ICD. And I've seen cases where someone has a Vtac and that is frequent and recurrent, and then he gets an ICD implant, and then he ends up presenting with 10 shocks. I mean, or an ICD is given appropriately in a patient with AFib RVR that's before controlling the AFib. So, before implanting, patient selection is important. Control the Vtac, control the AFib RVR is number one. And then, of course, correcting electrolytes, management of ischemia, management of CHF. Now, to reduce the shocks, if the patient has a stable VT that's sustained, more ATP therapy could be very helpful in reducing the shock. Increasing the duration of detection also helps. And then, of course, nowadays, I think Vtac ablation, what I've seen with ischemic, Vtac ablation is the best way to go. I mean, now we don't even a lot of times give a lot of amnio before we go to the Vtac ablation as a choice. It's really, I think, the most helpful with scar-mediated Vtac. And then improving hemodynamics, either treating the AFib or adding a LV lead is also another option. Now, if amnio fails, a lot of times we add mexiletine to amnio. Where sotalol fails, we add mexiletine to sotalol. That's another trick to play if you don't have an ablation as an option.
Perfect. I totally agree. So the so-called insensate VT or VT that is not controlled, totally agree with the assumption to implant an ICD for those patients, you may cause harm than benefit. So we have to control the VT first, then implant the ICD. However, if the patient comes with an ICD frequent shocks, which has already been implanted before, then definitely I totally agree with you, Sam. All those considerations should be taken.
Can I just add one
Sure.
little thing? I think patient with insistent VT, I think this is the problem Dr. Osama Belil talked about. I think to break the circuit, probably patient need to be sedated or even put into ITU fully in ITU for a day or 24 hours. Then very likely some of the adrenaline will settle down and probably the VT may ease. And then optimized medication, increase high doses of antiarrhythmic medications. So initially, and then add medication as Dr. Esam said. This is just a little bit of hint. The other thing I think to add is too much intervention sometimes can cause problems. So if the VT initially stable, tolerated by the patient, and the patient LV function not severely affected, then you could probably extend to avoid the shock, and also extend the VT zone as well. So that will avoid probably therapy as long as the patient is stable until you solve the problem by optimizing medical therapy. Every case is different, but try to minimize the recurrent shocks for the patient.
Definitely, yeah, and consider VT ablation. Obviously, that might help as well. Perfect.
Just one point to add,
yes,
دكتور عبد الغني إذا سمحت لي.
Sure, go ahead.
الزملاء في الإسعاف والعنايات, please don't forget أن الشوك is painful to the patient and painful to the ICD itself. لأن الاي سي دي الهاف لايف بتاعها هتنزل بسرعة مع كل شوك. فأي مريض يجيك storm ولا repeated shocks, please don't forget to put the magnet على ICD to disable the shocks, وthen you manage the patient زي ما قال دكتور محمد دكتور عصام في الاي سي يو.
Exactly. Depends on how frequent is the DVT. So it's just 1 or 2, then you just need to treat. If it's insistent, then you need to optimize the.
I think, Sam, I'm sorry about just this, my point. Regarding A&E doctors or medical doctors who really don't deal with cardiac patients, putting the ICD, putting the magnet on it, it will stop all therapies, and then the patient, if it is appropriate shocks, patient will arrest. So I think the difficulty of some, they cannot probably differentiate, and it is difficult whether this is AF fast and whether this is proper VT or VF or. So it is probably some cardiologist has to look into this quickly rather than the A&E team. They have to contact probably cardiologists to come in and look into the problem. This is what I will do probably.
Yeah, excellent point. I agree with you, Muhammad. Yusuf, do you mind if you can answer this question about the ICD recommended, not recommended, and for post-MI with ejection fraction less than 35 within 40 days, first 40 days. And if you can comment on that, then you add also they asked about the amiodarone or cortisone instead of ICD for those patients.
Yeah, MI would, ICD implantation within the first 40 days post-MI is contraindicated. زي ما قال عصام, based on Dynamite study. There's another one called ISIS trial. So there's at least 2 trials that showed that there's no mortality or no better outcomes in the first. Actually, there's maybe more mortality. زي ما قال عصام, at that time, طبعا الدول اللي كانت تقييمها في التسعينات حتكون أو بداية الألفينات, those patients would die maybe from complications of the MI. Not really, there could be arrhythmic death. That did show benefit in arrhythmic death. Like the patients would die because they would be really sick. So advanced heart failure, cardiac rupture, any other complications. So that's why within the أول 40 يوم we don't implant an ICD. Amiodarone can be used. Amiodarone, it was shown in trials, and it doesn't, compared to ICD, does not reduce mortality. لكن if the patient has VT, you can use it. Like if the patient does not have VT, don't use amiodarone. I would use beta blockers, ACE inhibitors, optimized medical therapy to help the ejection fraction improve. طبعا احنا موجوده في امريكا واكيد في اوروبا اللي هي الفيست, اللايف فيست. لايف فيست هذه عباره عن wearable external defibrillator, وفي trial published من سنه ولا سنتين ان there's no difference in outcomes. it does not help much. بس الترايل كانت نيجاتيف, لكن كان فيها مآخذ الترايل, لان لو تدير analysis للترايل حتلقى ان البيشنتس اللي really had arrhythmic events they survived. it did really help those patients who had VT and VF. لكن المشكله ان في هالبمرض ناس يموتوا من something else. They die from PE, they die from asystole, they die from advanced congestive heart failure. هذا ما عندك ما تدير له. within the first 40 days there's really not much to do. they're gonna die from non-arrhythmic etiology. في الأخير كلها حتكون أريثميا لكن non-arrhythmic etiology, it doesn't help that much. بس على العموم اللايف فيست is something that can be used. احنا في ليبيا عارف مش موجودة اللايف فيست, لكن هذه نقطة ثانية مجرد حبيت نذكرها. فبوتtom line هذا I hope it covered.
Allah يبارك فيك Yusuf, totally agree with you. The main reason for this to avoid ICD in the first 40 days is the high chance of recovery of the LV function with optimal medical therapy and revascularization. Ejection fraction 20%, you give them LED stent and optimal medical therapy. You repeat the echo in like 20 or 30 days, you'll see ejection fraction about 50%. We see it all the time. Main thing is, as Yusuf mentioned, optimize medical therapy and give them the full dose as per guidelines.
Those patients who improve, they'll improve regardless with an ICD or not an ICD. ICD is not going to prevent death in the first 40 days. That's the bottom line. Or at least it didn't seem to have helped reduce mortality.
Exactly. Yeah. The ICD only to prevent sudden death, doesn't treat. We said that at the beginning. Excellent.
طبعا unless there's a VT لو اي مريض عنده VT اكثر من 72 ساعه after an MI there's an indication of ICD يعني monomorphic sustained VT ICD should be implanted.
Exactly. That's secondary prevention. Yeah, definitely. Not fair. Yeah. في سؤال ممكن نعطيه عصام if you don't mind to speak a couple of words about the leadless or subcutaneous ICD. I think you mentioned that nicely. And if you can just answer this question. I see دكتور معلش عصام لو سمحت بس دكتور العقلي تسمع فينا دكتور العقلي. رضا.
نعم السلام عليكم ورحمة الله.
السلام ورحمة الله.
أسمع فيك.
طيب إن شاء الله.
First of all, let me thank the Libyan Cardiac Society, Dr. Abu Nuwara and Dr. Esam and colleagues for making this really magnificent presentation. 15 years ago, I attended as a humble surgeon, I attended an EP meeting in Saudi Arabia, and I was terribly impressed by the Saudi Electrophysiology Society at that time. And I'm very pleased today to say that I am also impressed today with your presentation and the discussion that I've seen, although it's far beyond my area of expertise. But as a cardiac surgeon, I would like to point out two things that my personal experience, I have seen patients who had cardiac tamponade post attempts. Actually, it was trying to remove pacemaker or ICD leads using some laser gadget about 10 years ago in Saudi Arabia. But it's important to keep that in mind, and these complications are treatable if the patient is actually managed adequately and in good time. The question I have that patients who have cardiac pacemakers coming to surgery, we often use a monopolar diathermy. I'd like to know if a patient come with ICD for surgery today, how should we manage that patient? Because that would be a useful thing to know. Thank you.
You're welcome. Nice to hear from you again, Rida. Very nice to see you in person. Okay, Esam, do you mind to?
Yeah, for ICD, a magnet should be more than enough. They put a magnet, and as long as they're having shocking pads on the patient, so they can defibrillate if something happens during the procedure, and they can have a magnet on the ICD. It will continue to pace, and it will not falsely oversends the EMI from the cautery.
And can we use bipolar or only monopolar diathermy?
If you put a magnet on the ICD, I think there should be no difference.
Unipolar طبعا it doesn't دكتور رضا أهلا وسهلا بك. Unipolar doesn't, it's safer لكن can you use unipolar in cardiac surgery؟ هذا السؤال ليك يعني بقى.
Yeah, sure. I think in
لا سامحني bipolar بالعكس bipolar is safer than it's local. Unipolar you have to put them أنا عكستها. Bipolar you have to put the patch on the thigh والcautery في الchest ولا؟
Yeah,
that's bipolar. Bipolar is going to be more to the step of the bipolar, less risk of noise.
Yes.
But it's safer.
My understanding is different. Yes. My understanding that the patient is pacemaker dependent. We use monopolar diathermy, not bipolar. Unless maybe I got it wrong.
Dr. Lockley, بالنسبة لي, if there is availability of physiologists who could disable the therapy of the device, disable the therapy. So there will be no therapy and put pads like a defibrillator on the side just in case there is a cardiac arrest. So you disable the therapy and the pacemaker can work. Okay. If the patient is pacemaker dependent, you need to use the bipolar, and intermittently you have to keep an eye on the ECG throughout the time. So you don't give your diathermy all the time continuously. You have to look into inhibitions, and the best thing to be done with the physiologist with you in theater itself. So physiologist to attend, physiologist to disable, and after the surgery, physiologist to program the device as it was prior to the admission to theater.
دكتور محمد نضيف الماجنت لو حطيته على البيس ميكر يا دكتور رضا it's going to do asynchronous pacing. يعني لو patient pacemaker dependent وحطيت magnet عليه, it's still going to continue pacing, even if you give electrocautery, even if you stay on. The ICD, if you put the magnet, is just disables therapy, so the patient doesn't get shocked. زي ما قال دكتور محمد, it's always important to put pads, لأن that's your backup. لو البيشنت صارت له حاجة, the ICD is not going to shock the patient. وطبعا programming the device would be the best thing, زي ما قال دكتور محمد.
Thank you. Clear.
Yeah, you're welcome. I totally agree with these comments. I was planning to add, but it's well answered. I think you just do those steps and your patient will be safe, inshallah. Okay. Esam, معلش بنرجع لك ثاني على leadless ICD. You mentioned that early on, and if you can comment briefly the difference between them, especially the availability and the cost.
The subcutaneous ICD, the lead is implanted under the skin. The cost of a subcutaneous ICD, that I'm not sure of, honestly. Availability in Libya, you mean? I don't know.
Generally
I don't think
speaking,
it's available for Libya.
It
no,
is?
but the cost is the same. I've heard from our companies here. The cost is actually the same. So most of our people here use the, if possible, we use the subcutaneous ICDs if there is no need for pacing. If you don't think the patient might need pacing in the near future, because there is no pacing capability for the subcutaneous, that's a huge difference between the subcutaneous and the intravenous ICDs. So most people now actually moving forward because it's less invasive and has less complications. As Dr. Oakley mentioned, the tamponade and other perforation that won't happen because everything is under the skin. So I think that's a huge difference.
Can I comment on subcutaneous
Please, yeah.
ICDs?
Sure, yeah.
Subcutaneous ICDs definitely في حتى trial published توا Baryun تقريبا اسمها. And there's no difference between single chamber ICD subcutaneous ICD. لكن وفعلا no vascular complications, no risk of tamponade essentially, no pneumothorax. فطبعا a lot of benefits. لكن في شوية limitations of subcutaneous ICD. It's implanted under the skin. مرات السensing, I've seen patients before T-wave over sensing. T-wave over sensing is much higher with subcutaneous ICD compared to single chamber ICD. فهذه limitation عندهم. وحاولوا هم يحسنوها بسم algorithms لكن ما زال قاعدة not perfect. احنا بالنسبة لنا في ليبيا يعني if we can do single chamber ICD this is perfect يعني لأن subcutaneous ICD يعني perfect في patients young patient برغادة مثلا أو channelopathy أو هيك definitely don't need pacing لو ما عندهمش bradycardia وpreserve الفاسكولاتشر يعني واحد عمره 30 سنة ولا 40 سنة تقعد كل 10 سنين تحط له new ICD it's hardware it gets يعني he's gonna need multiple replacement فطبعا subcutaneous ICD ممتاز في الحالة زي هذه لكن most patients you can manage with a single chamber ICD that's my opinion يعني.
Yeah, again, the advantage of the subcutaneous, like Minnie mentioned, is also the lead is less risk of fracture. And then less risk of infection, especially in dialysis patients. And also the clavicular crush in very active young people. You know, the leads can get crushed if you do transvenous, but there's less risk of crush with subcutaneous. The problem with subcutaneous, of course, nowadays we don't implant them under the skin. We have to implant them under the muscle to get closer to the heart and to improve the shock impedance. But in general, if the patient needs pacing, then or CRT, either pacing in the A or pacing in the LV, IV pacing, then it could be an issue. But again, I think adding the obese patients, I really cannot. If I have a really big morbidly obese patient, I don't know that I could, with high risk of sudden cardiac death, I don't feel comfortable implanting a subcutaneous ICD.
Definitely, yeah. It's a selective approach, definitely, yeah. Especially patients requiring pacing or not, that's a big decision you have to make. Excellent. Dr. Osama Bahlil, do you hear me? If you can comment on that. In Libya, do you have any cases with wireless, and what's the cost there?
حقيقة بالنسبة لنا احنا طبعا ما عندناش السبكوتينيوس ICD، ومن تقريبا من اسبوعين او 3 اسابيع كلمني دكتور خالد سوينيا في مريضة مركبة سبكوتينيوس ICD في المانيا، فقلت له ابعثها لالمانيا لان الحقيقة احنا ما عندناش الاكسبيرينس معها. no idea، والحقيقة I haven't seen any patient with subcutaneous ICD. غير سؤال واحد بس، هل شركة بوسطن هي الوحيدة اللي تصنع فيه ولا في other companies بالنسبة للسبكوتينيوس ICD؟
شركة بوسطن بس، بوسطن ساينتفك.
Yeah, Medtronic still not approved. Yeah, Medtronic is still not approved. Like in حاليا Boston's only.
What we have is Boston Scientific, but most likely it will pick up, and most of the companies will take the same technology.
لكن زي ما قلت لك في ليبيا للأسف شديد لا ما عندناش.
والother ICDs موجود يا أسامة available to everybody for the transvenous ICDs, or how's the cost?
هو تقدر تقول available و not available، يعني الحكاية بلسطايل في ليبيا. Sometimes you have ICDs, most of the time not. ممكن دكتور رضا عنده كومنت عن الموضوع هذا باعتباره هو أكثر منه دراية في الأمور هذه، لكن في ليبيا الحكاية بلسطايل. الوقت الحالي في الكات لاب على الأقل نحكي على مستشفى طرابلس الجامعي we don't have ICDs. عندنا 2 pieces for change DF1 مخلينا للتشينج للبيشنتس ممكن يجوا ب old devices، لكن we don't have.
Yeah, Dr. Reda, would you want to comment on that? Dr. Al-Oakley?
Thank you. Thank you very much. I think the difficulty طبعا with supplies in Libya is a big story. I think the إمداد الطبي have 1.2 billion Libyan dinars a year. But unfortunately, a lot of that is wasted in many different ways, to say the least. The other very cumbersome thing we're going through now is that the Ministry of Health cannot pay a hospital, for example, Triple Medical Center, for example, to do open heart surgery after the department has failed to do that. They cannot pay them 35,000 Libyan dinar to do the case. And I'm sure they will not be able to do the same for pacemaker implantation. But what they do, which is really something mind-boggling, is that they go and pay a company, a third party, 35,000 Libyan dinar, and that third party will pay the team, the surgical team who is working in the hospital or maybe working in a different hospital to come and do the operation in Tripoli Medical Center or Benghazi Medical Center or Hawari as it is happening. And I'm sure the same can be done, but it's really a very confusing and a very, what's the word, maybe tortuous way to make funds available for life-saving procedures. I think it's absolutely necessary to be able to implant ICDs where indicated in these patients in government hospitals without having to wait 2 to 3 times the price for that through this difficult way to do it. But I think the good news that we have now is that اللي هو طبعا صندوق التأمين الصحي برئاسة الزميل والصديق الدكتور طلال حجاج now is offering a pilot project for health insurance for the retirees, number one, and now, upon the request of the Prime Minister yesterday, they will be able to offer it for people above the age of 62, 60 as well, 60 to 65, which is the retirement age. But that will be done, I think, through specific private hospitals. It will not be open for government hospitals for one simple reason, that if any money is paid to a government hospital today, the funding regulations or the legal regulations does not allow the hospital or the team working in that hospital to benefit from that money. The money goes للخزانة أو لوزارة المالية, and the hospital will be left just wondering where did the money go. So it's a very silly way. الآن ممكن نتكلم عليها باللغة العربية أنه هو لكي نسمح لأي مستشفى أو أي مرفق صحي داخل ليبيا باستخدام طرق يعني تدر عليه عائد مالي. هذه العوائد المالية لا يمكن أن يستفيد منها المركز مباشرة أو المستشفى مباشرة، بل تذهب إلى الخزانة العامة ووزارة المالية. ولما يجي المستشفى تخاطب وزارة المالية أو الخزانة العامة تقول لها باي أنا درت 10 ICD أو حالات ICD تكلفتهم ممكن 500,000 ولا مليون دينار، وهذين الفلوس اندفعن ومشان للخزانة، ردهم المستشفى يقول لك لا، القانون لا يسمح، لأن المستشفى عندها ميزانية معدة مسبقا معتمدة من العام الماضي، وأنا لا أستطيع أن نضيف يعني أي تحويل مالي فوق ذلك، فوق تلك الميزانية. فنحن في حاجة الآن إلى إعادة النظر في القانون الصحي بصفة عامة بحيث يتناغم مع وضع قطاع الصحة اليوم، وخاصة بشأن التمويل إن شاء الله. شكرا.
Allah يبارك فيك Dr. Locke. Well done, well answered, and I really appreciate your insight about that. Very, very helpful to know the medical perspective and also the logistic perspective. As a physician, when you see the patient and say the patient needs an ICD, we have to think about those logistics, because that takes us to this question, and hopefully we'll wrap up in a few minutes. Is if the patient refused an ICD ablation, or I might add, if there's not available, which drug combination you would use to treat this patient? Dr. Mohammed Abutwarat, I think you have a comment, and then you can answer this question also.
Barakallahu feek. The question, what I think regarding ICD in Libya, for example, where there is no facility for ICD or availability of ICD. Depends on the etiology of the problem, and always try to discuss with the patient all the options available and try to be safe. I mean, in the choices. So the safest drug for long-term use has to be used first, and to give the patient the options, of course, regarding this. Patient with there are contraindications. All of you probably know about it. I mean, using antiarrhythmic medication for long term, you have to explain the possible side effects and how to be avoided. And amiodarone is widely used in Libya, and I think very widely used in Libya, and even for patients with just controlling AF or SVT. I think that has to change a little bit, and people should really know more about using safe antiarrhythmic medication, like using beta blocker, different types. I think for I mean the use of beta blocker, bisoprolol or sotalol, depending on the etiology, and the dose can be increased and adjusted according to the problem, instead of going straight to amiodarone. Using I mean, I think that's my first thing. Even if you fear that there is probably COPD or asthma, and asthma is very well controlled, and patients not using inhalers regularly, you can still use beta blockers safely. If you are too worried, admit the patient, give beta blocker. Try to use the safe drug for long term. If there is a problem, then you can introduce amiodarone. If you can't use sotalol in good dose, the dose of sotalol can go quite high. And then amiodarone, you have to have a baseline check, and you have to inform the patients and the way how it can be followed to avoid problems in the future. Try not to keep the patient for a long time. If there is a VT, can be treated with ablation, direct the patient even to go outside to have a VT ablation instead of staying on toxic drug for a long time. Optimize heart failure treatment. Try to improve the heart function. Try to avoid antiarrhythmic medication by just optimize heart failure treatment. Flecainide, depending on the etiology and the problem, can be used to avoid an ischemic heart disease. But I mean, if there is normal LV function and you see that there is indication for it, it's at least less toxic than the amiodarone. Those are the measures, really. Try to add beta blocker if you are using flecainide for a reason. So try to keep it under control as well, and beta blocker on board as well. Mexiletine in very desperate situation, which is very rare to be found. It's very difficult to get. You can use it as well. Mexiletine, 3 times a day dose, even with amiodarone. But these are the desperate, really very desperate situations. Otherwise, as I said, always look into the safest medication for long-term use.
Thank you. Thank you. Very wonderful answered question, and really well done. I agree with you. You kept insisting and saying beta blockers, which I totally agree with you. Beta blockers are very safe, effective. Beta selective can be used in COPD and mild asthma, and you can titrate up. The biggest thing to do is to treat them to improve their ejection fraction. That's the best way to prevent arrhythmia and prevent ICDs. And remember, we have limited choices. If you have low ejection fraction, heart failure, and ischemic heart disease, you're limited to like amiodarone and probably defibrillate in addition to beta blockers. So you have to be careful. Look, as Dr. Turat mentioned, the etiology is important to know and focus on treating them to improve their ejection fraction. We know, like, for example, in Entresto now, there's evidence that it also reduces sudden death somehow. So don't forget about those medications to treat. So I think we had an excellent discussion, and I think the time is running by now. I would just wrap up here, and I'll give a chance to all of us guys, Dr. Esam Baryun, Dr. Turat, Dr. Bahir Yusuf Al-Darrat, to say a couple of words before we close. Dr. Mohammed Turat, you want to say something? Yeah, go ahead, please.
Just one thing to add, because you mentioned interest, I want to say that cardiac rehab post-MI is probably similar in benefit to patients, okay? In 28% improvement. So, I mean, you have to look into cardiac rehab for patients post-MI. That's very important.
Thank you. Excellent.
Thanks.
Dr. Esam Baryun, you want to say a couple of words, just wrapping up and closing?
No, I thank you all. شكرا لكم. بارك الله فيكم. ما فيش حاجة بصراحة نضيفها يعني.
شكرا. جزاك الله خير. Excellent presentation, Dr. Esam Baryun. Dr. Osam Hilil, any final comments or words?
شكرا دكتور عصام، شكرا دكتور عبد الغني. You were very good moderator الحقيقة اليوم، بارك الله فيك. شكرا للزملاء على النايس ديسكشن، وتمنيت ان الشباب كلهم استفادوا من الليكتشر. وان شاء الله تكون في ليكتشرز مستقبليه على how to treat some points زي مثلا الالكتريكال ستورم، some EGMs للبيشنتس او للدكاتره اللي يشتغلوا على الديفايس كلينيك. طبعا احنا عندنا مجموعه شباب يشتغلوا في الديفايس كلينيك في التريبل يونيفرسيتي هوسبيتال، فمرات يكون في dedicated future lectures how to deal with some intracardiac EGMs, some problems، يعني focusing على الجروب معين يعني. وشكرا جزيلا.
شكرا، جزاك الله خير. اوكي دكتور يوسف الضرات.
بارك الله فيكم. شكرا عصام، great presentation. شكرا عبد الغني، great moderation. يعني you did a great job. هلبة حاجات في نفس الوقت صعبة، المودريشن مش سهلة. بارك الله فيك. وبارك الله فيك دكتور محمد على وجوده اليوم، وعلى أسامة بهليل، وأيضا الدكتور رضا شرفنا بحضوره. المحاضرة ممتازة إن شاء الله الكل استفاد. بس أنا حبيت نعلق على دكتور أسامة، إن شاء الله بإذن الله المحاضرة الجاية حتكون طبعا نتيجة رمضان، إن شاء الله حتكون في شهر 5، وحتكون إن شاء الله دكتورة نادية السني she's gonna present على ICD case based scenarios. فإن شاء الله ممكن نقدم EGMs بحيث الحضور يستفيد يعني بإذن الله يعني. وبارك الله فيكم. شكرا.
إن شاء الله. بارك الله فيكم جميعا. بارك الله في الحضور، وشكرا على excellent presentation دكتور عصام بريون. شكرا للexpert panel on their fantastic comments and input. It was wonderful. Inshallah, we'll see you next time, and please remember the upcoming conference, the Libyan Cardiac Society conference in July. Inshallah, try to register and try to attend. جزاكم الله خيرا جميعا، ونشوفكم إن شاء الله next time. Have a good day. السلام عليكم ورحمة الله وبركاته.